application. In your practice, it's important that you set a room or a system so that you can have safe POP application. This should include POP table. There are various types, but you could just use a normal examination couch or a special designed extended table, or sometimes you can have special reduction frames like for hip spiker. Of course, in the same room, you need a POP trolley that has various shelves and cabinets to where you can safely store bandages, padding materials such as cotton wool, supports, blocks. You need a packet for water or any other wetting agent. You need to have heating facilities because at times it's recommended to have warm water. Of course, you need paper like polythene to protect the patient, floor, and of course, yourselves. The room should be spacious, should have room to keep equipment and safe presence of having assistance. Of course, in this era of COVID, we now are talking about safe social distance, at least a spacious room will mean staff safety. Of course, once you have all that set up, then of course POP application as a process. First of all, the region of the limb or the body that you're going to apply requires adequate padding. And usually we need to use cotton, which comes in very many preparations, or a stockinette. Of course, the application process, once you've applied your layers as required, then you go on to molding. Of course, setting and drying. This process is a factor of time. So it takes time to pad, it takes time to apply appropriately and mold. And of course, you need to give some moments for setting and drying before you release the patient. Non-operative management of fractures, like operative management, you need a team, a POP application team. You need a clinician, and I want to emphasize, a lot of times you've seen doctors in emergencies or treatment areas, they usually prescribe POP application. Patient proceeds to POP room where you've got a technician only and absence of a clinician. I think we want to re-emphasize here that you modify your system so that it allows the presence of a clinician, of course, a plaster technician or technologist and assistant. So the role of the clinician is for reduction of the fracture, maintaining the reduction in a safe position. The technician then applies the padding and applies the POP, while the clinician is maintaining the reduction and safe limb joint position. Of course, after application, both the clinician and the technician should mold the POP. Of course, while molding, support the POP with the flat of the hand, with the palm and fingers open and straight. You may need a third person, and that makes work easier if you can afford the resource. Of course, after application of the POP, it requires care. Of course, it starts immediately. Elevate the limb and explain to the patient the importance of elevation. The first 36 hours, preferably, we recommend no cover of POP with padding or any other form of clothing. Immediately check circulation, focusing on skin color, capillary refill, record pain points, very critical to be able to tell whether you're dealing with excessive pressure or prominent or compartment syndrome. Of course, pain characteristic. Always ask the patient to come within 24 or at most 48 hours. There is always this common practice where many centers across the country where people ask patients to come after 6 weeks. We need to discourage this because this is unsafe practice. From now on, we will have a series of pictures, diagrams to illustrate the types of techniques, the type of methods, the type of available POP or splints. For example, here we have a hanging cast indicated for shaft humerus. All right. Then on your extreme right, we have a brace, functional brace. Of course, after you've done your hanging cast, you got core and cuff. This core and cuff can come in many forms of material design. It's an example of a U-slab, again for proximal humeral fractures, also shaft fractures, and core and cuff, as it is done from the available taping material. An example of above elbow posterior slab, a very, very commonly used slab in distal humerus and injuries around the joint. You can also use it for temporary support of shaft, radius, and ulna. But the critical point here is it has to start from the distal palmar crease, the elbows to be in 90 degrees, the arm in neutral to pronation, and proximally to a point below the margin of the deltoid muscle. This is an example of a circular below elbows cast or POP. Again, you have to see the landmarks, the positioning, and the shape. All right, and of course, the position of safety. This is a thumb spiker. This is commonly used for the first lay, starting with the scaphoid, the first couple, metacarpal fractures or dislocation or soft tissue injuries. Again, look at the position, the margins. Okay. This one here is dorsal extension splint. We also call it back halter. It's quite very important, again, very commonly used splint. This splint we need to emphasize. You don't often see it being applied, but we need to emphasize it. It is a splint that is usually formed of two slabs, an anterior slab, which reaches the distal palmar crease, and a posterior slab that goes all the way to the PIP. Okay, to the PIP, the IP joint. It allows full extension of the fingers. Okay, it prevents extension of the fingers at 90 degrees of MTP joint, but it can allow flexion at all levels of the IP and the DIP joints. Okay, a very important splint for metacarpals and the MTP injuries and even fracture tendon injuries. Here we have a paddy splinting or butt strapping. These are very important splint, and it is commonly indicated in fracture tendon injuries, also extension tendon, finger tendon injuries. It can also be used for the middle phalanx or fingertip injuries, are very friendly. It can also be used in combination with the back halter or the dorsal block splint, POP. Here, moving to the lower limb, we have below knee POP. Of course, we have an elbow axillary crutch there. Here, what you need to note is the boundaries, okay, and the position of the ankle joint. Obviously, number one emphasizes elevation principle. Now, this is a segmental cast, also known as patellar tendon bearing, PTB cast. This is one cast that is not commonly used, but we are emphasizing that for those who use plaster to manage shaft tibia, and distal tibia, particularly metaphyseal diaphyseal junction tibia fractures, where you do an above knee POP, circular POP, after 3 weeks or 6 weeks, you can actually use a PTB to functionalize knee exercises, whereby for the rest of the time of healing of the shaft tibia fracture, which often takes 16 weeks to 24 weeks, you can use a submental cast. This allows the patient to weight bear, improving secondary healing, and at the same time functionalize the knee to prevent knee stiffness. Here, a non-operative method, especially in emergencies or in transport, is pelvic binder, or basically what you can call pelvis splint. Okay, you can modify this with a bed sheet, or there are other. This is basically to illustrate the principle. Again, traction. There are 3 types of traction as a method of non-operative treatment: fixed, balanced, and combined. Of course, the techniques of applying fixed, balanced, or combined traction is through skin traction or skeletal traction. I'll illustrate this with a series of pictures and diagrams again. This is a fixed skin traction, very good for transport or temporary immobilization of femur, shaft to knee, or even tibia fractures while awaiting definitive treatment or transporting from one facility to another. This one is a fixed traction using a stoma splint, but at the same time allowing you to do elevation either over the lower bed, the lower section of the bed, or a brown splint. Again, this could be temporary while you await definitive fixation. Of course, this is a Thomas splint. I hope you do have this type of splints in your respective facilities. This is still a very important non-operative tool, either for temporary or for definitive treatment where applicable. This is a very, very commonly used skin traction. Okay, you can use it either definitively to treat shaft fractures, especially in immature skeleton, like children between 4 to 12 years, over aduvation to allow the fracture become sticky, and of course you can change to POP, or simply you can use this for temporary mobilization of shaft femur fractures, distal femur fractures, even proximal femur fractures, while you are waiting to do definitive treatment. Very important to control pain, to stabilize the patient while you are planning final treatment of respective fractures where it's indicated. This should be very universal. Almost every facility should be able to access skin traction kits. This is, of course, balance traction, which, of course, it is a combination traction method where you got a skin traction, you got pulley, elevation of the lower side of the bed, particularly in children. It's very commonly and popular, very safe method of immobilizing and therefore treating fracture shaft femur, even after reducing hip dislocation, even in adults, you can actually use it for a time you want to immobilize the patient or our patient on bed rest. A very important skin traction. Because this balance, the reason for balance is that the traction is provided by the weight and counter traction by the body weight. And this is achieved by elevating the foot off the bed using a 6-inch block, or basically a stool. One thing I want to mention here is that if you have this system in your hospital, ensure that the weight conform to the Kenya Bureau of standards, and these weights can come in form of over kg, in grades of halves or ones, kgs up to 5. The bullies don't have to be very standard, but it should function as a pulley. Otherwise, the blocks, again, you can standardize them. So that is how you can come up with your system that can help you to use balanced skin traction as a technique for non-operative fracture treatment in your respective practices. Sorry for that interruption. Okay. Next is balanced skeletal traction. Again, previously this used to be a definitive method of treatment in centers where yet you don't have ability to do surgeries. You still can use skeletal traction to treat fracture femur where it's indicated, both in adults and in bigger children. This is a combination that uses a series of complicated bully system, okay, slings, skin traction. You can also use skeletal traction. Those who are at Kenyatta National Hospital, they do have this system and they can appreciate this picture. Braces and splints, of course, this is a thumb spiker splints, but these are what you call ready-made, and you can get them either from your hospital supply chain system or suppliers who stock these within your practice reach. And you can start all the way from the finger splints to MCP to wrist splints to elbow, shoulder, spine, from cervical supports, chorus braces to thoracic, lumbar, sacral, thoracolumbar junction, even hip joint braces, thigh, knee, leg, ankle, foot, and the all range of the A4 functional braces. One thing we need to mention here is this is a group of splints used for non-operative treatment that are stepped down from POP or casts or traction. Okay, in minor injuries, particularly soft tissue injuries or non-displaced fractures that are very stable, you still can use them primarily as definitive treatment to immobilize your fracture. One thing we've seen in terms of safe care and patient satisfaction, for you to be able to improve this score, you could immediately after POP or cast give a patient a brace. Of course, it has a cost implication. So where the patient is able to afford them, they are quite very useful. They allow early return to work. They also allow confidence, and yes, patient confidence. All right, for them to be able to start to turn back to work, and that allows immobilization and compliance to or adherence to physiotherapy or rehabilitation program. After covering the various categories or of non-operative treatment techniques across the splints, cuts, and skeletal traction, I guess after looking at each picture, the particular indication of each splint is assumed or self-evident. Now let's look at what are the overarching principles of treating non-operative patients. Number one, always rule out or attend to life-threatening injuries before you attend to specific fracture using the ATLS principle. This cannot be overemphasized. Of course, after the patient is safe as a whole, you have to look at limb-threatening injuries like pressure to nerves, joint dislocations, and open wounds or injury to vascular supply. And of course, we need to look at hospital resources and ability of patient to afford any preferred method of treatment. The next principle is investigation. Once the patient is very stable and you stabilize the limb, always investigate. Investigation using X-rays helps you to confirm the fracture, to classify it, and also to plan your treatment, and also use your resources judiciously. If someone has very severe injury, of course, we do the three series, and then of course you do the epilateral, orthogonal views, and special views were indicated. For patients who have chest abdominal injuries, having an ultrasound check is important. Of course, lab tests, ECG, CT scan, and MRI where they are indicated. The fourth principle is actually the actual 4 principles we use in non-operative management. The same principles actually apply in operative treatment, and these include reduction, immobilization, rehabilitation, and safety. And reduction, the overarching goals is where reduction is indicated, aim at alignment, position, rotation, and limb length. Of course, the reduction approaches in crossed methods is always ensure you got adequate pain control. Please be as human as possible. Always ensure there is very good pain control before you start any manipulative process, because it's very, very painful. Be compassionate to your patient. So ensure there is anesthesia. You can do hematoma probe, you can do regional block, or you can actually do consent sedation or general anesthesia. But remember the cost to this. Of course, number one, after understanding the mechanism of injury and the type of displacement, you disimpact the fracture, reverse the mechanism, and restore the deformity, then hold the fragment together. Once you held like this, if you choose to use POP or cast, get your assistant to apply, you do the molding and maintain until the cast or the POP is set. If it's traction, you must understand the principles like counter traction, the use of gravitational forces versus counter traction. Of course, we have direct reduction, which is not a subject for today. Once you have reduced, the next principle is you immobilize the fracture. Immobilize the fracture, but mobilize the adjacent joints and the patient. Now, the reason why we must immobilize is to ensure the fracture does not displace again, because there is a tendency to displace. Prevent movement that is excess, that interferes with healing, and of course, importantly to the patient is relief of pain, and allow healing. The methods, we have already gone through it. Of course, the next principle is post-immobilization. Check X-ray, check circulation, check the entire patient, and of course, have a follow-up plan. Of course, the follow-up plan will be advised by the hearing process, and this is a broad guideline. This is a very popular slide, and obviously there's a rule like upper limb 3 weeks, 6 weeks in adults, lower limb 6 weeks, 12 weeks in adults, but this can vary, can stretch to 12 weeks and 24 weeks respectively, given other factors, complexity of the fracture and the energy, the amount of energy. And if, for example, the fracture is open, definitely healing time is prolonged. So this allows you to decide immobilization duration and follow-up plan. Next is rehabilitation. I want to emphasize it starts immediately. Immediately. The patient should be able to move the adjacent joints and provide immobilization for the patient. And patient is encouraged, and the patient has to take that responsibility to move as a whole, move the limbs and free joints, of course, as much as the pain can allow. Having said this, and covering the types of non-operative method and their uses, the principles with which guide us how we treat non-operative fractures that we see commonly in our practice, and how to ensure we have appropriate plan from setting the room, ensuring their materials, understanding the mechanism, having an assistant. This leads to satisfactory non-operative reduction or management of fractures and good outcome. And of course, I've implied you need to formulate your system at your various hospitals and practice places so that you can be able to use non-operative methods safely for good outcome. I think with that, I come to the end of my presentation on non-operative management of fractures.
Thank you, Dr. Kari, for the presentation. I believe it was nice, clear, and precise. We have a couple of questions. At your taskbar, you can see the Q&A. So Mbuva Bondface asks, please explain which of these joints, DIP and PIP joints.
Okay. DIP joints is distal interphalangeal joints. PIP is proximal interphalangeal joints. Now, the PIP, okay, for the digit second, third, fourth, and fifth, we have 3 phalanges. For the first digit, which is the thumb, we have 2 phalanges. So for digits 2, 3, 4, and 5, we have a proximal, middle, and distal phalanges. So the PIP is the joint formed by the proximal phalange and the middle phalanges of digit 4, 2, 3, 4, and 5. The DIP is the joint formed between the middle phalanges and the third distal phalanges of digits 2, 3, 4, and 5. So for the thumb, you need to realize it doesn't have PIP or DIP joints.
All right, thank you. The next one is from Zachary. He says, thanks for the good presentation. Why is it sometimes in trauma center, most fractures, even simple, which can be managed in a cast, some orthopedic surgeons go in and operate such cases?
Thank you very much. Good question. Okay, those centers, number one, they got resources. All right, this is from personnel to ability to pay for surgery. Surgery is expensive. But again, those who have also worked in those centers in terms of fellowships, you actually realize in these centers, they do operative, and at the same time, they end up, giving the patient a splint. It could be a POP, it could be a brace. So still, though, in those centers, those doctors, clinicians, they still learn the principles of safe, non-operative splinting of fractures. Yeah. Now, in our setup, sometimes you may want to do surgery even when it's indicated, but the surgery is not available, or the implant is not available. Or sometimes it's very unsafe to do surgery because of the risk of infection, and of course the cost to it. Yeah, I mean, I work at MTRH. We could want to do surgery, but we cannot do because there is no room, or maybe the patient cannot afford. So we end up, compromising and giving a patient a non-operative option. But where there is absolute indication for surgery, we give the patient priority. But the point here and the objective of this presentation is that even where you can do surgery, but at the same time, you can be able to do non-operative treatment. The point is, non-operative treatment, you need to understand the principle, right, of safe application, maintaining the goal of alignment, rotation, limb length, apply on the right duration, rehabilitate the patient properly for good function. Otherwise, in poor hands, complications can be quite high. You end up with stiffness, you end up with malunion, or yeah, and the patient become really very dissatisfied. Thanks.
All right. The next question is, does skin traction cause fracture reduction?
Yes. For example, the balanced skin traction that I emphasized on immature bones, children between, say, 4 years to 12. All right. You don't have to put hematoma on the shaft, femur fracture on a child. You just need to apply skin traction, often done below the knee. You can extend it above the knee, but must be below the fracture point. As long as you elevate the foot of the bed 6 inches and that you got appropriate weight for the weight, okay, and the condition of the skin. Usually when the muscles relax, which takes about 3 to 4 days, the body weight of the child counter traction on the weight that you put on the skin traction actually causes reduction of the fracture. If you put excess weight, not only can it cause skin complications, but can over distract the fracture. Yes, the answer is skin traction can be used as a reduction technique for fracture, and I've given that example.
All right. The other question is Dr. Stan Kim. She's asking, how many of us use Chinese finger traps, especially for distal radius fractures? I think that's for generally most of the guys who are here. I don't know, do you use them, Dr. Ongaro?
Yes, we do use them. We got Chinese finger trapping at MTRH in theater. It's a very good tool. I mean, it's very versatile, especially where in theater, mainly, where you use it as an indirect method of reduction. You see, nowadays you can do indirect reduction, okay, and actually use percutaneous fixation of fractures, all right. And if, for example, we are talking of distal radius or distal humerus in children, where you reduce and then do percutaneous, and then you apply POP, which is a combination treatment of both non-operative and operative treatment. What I'm trying to say is that Chinese finger trap, in absence of having an assistant, can help you to manipulate and maintain the traction the way you want it. Now, so that you got free hand to be able to apply your POP. You have to learn to use it, all right? And you need to be warned again. After a while, it can cause extreme pain. And so you have to be ready. You have to put your materials ready. You know, everything is within reach using the Kaizen principle, so that within like half an hour, 30 minutes max, you are done with your procedure. Of course, on Chinese finger traps, like I said, is a versatile tool. You can use it for shoulder surgeries, okay, and even arthroscopy. All right. Even when you are just doing draping, preparing for draping a patient for whatever procedure on the upper limb, where you don't have an assistant to help you elevate as you clean and drape, Chinese finger traps are quite important. There is a colleague in Sambweni, I forget his name, who actually makes them. Whoever knows the contact can share with the colleague so that he can be able to make them for people who may want to use them.
I think it would be important to get that contact. Most of us have only seen them during the trainings, I think, for the younger surgeons coming up. All right, the next question is, please clarify the difference between fixed and balanced traction.
Good. Fixed traction and balanced traction. First of all, a balanced traction is where you put your traction to give a traction force. Now, this traction weight or force is balanced with the body weight, your body weight, patient's body weight. And the example is what I've just given, the one using pediatrics. Fixed traction, we a lot of times use it in the in fracture shaft femur, particularly in adults, where you pull the fracture with the aim of reducing the fracture. Once you're manipulated and you have achieved your desired reduction, then you fix the fracture in reduced position. So a fixed fracture, a fixed traction is not a reduction tool or technique. It is a maintaining technique. So the example is where we use the Thomas splint. Once you've reduced your fracture femur shaft, then you apply your Thomas splint proximally. You ensure that the Thomas splint that's well padded is hinging on the groin and on the greater trochanter. And actually, that's a fixed point. Then you apply your skin traction, reduce your fracture, and then using the cord on the distal end of the Thomas splint, you fix the limb in that position. Good for temporary fracture reduction and pain control, and quite safe as you wait for definitive treatment of the shaft fracture, or like I said, when you are transporting the patient from one center to another. I hope that point is clear, the difference between fixed and balanced.
All right.
One more note of balance. If you remove the weight, you lose the reduction. Or if you keep the bed flat, you don't have a balance. So your reduction is useless. I mean, your skin traction is useless.
Okay.
Yeah.
Then the next question is from Charles. Sorry, this is not giving me your title, so I'm just reading as it appears. In the treatment of colles fracture, do you use below elbow cast only?
Yes, specifically colles fracture in elderly that can survive.
Okay.
And it has to be strictly colles fracture, which is a simple extra articular transverse fracture, and the fracture out of necessity as key. Once you reduce, the fracture lock into each other. And of course, when you put it in a bit of flexion and a bit of ulnar deviation, the below knee circular POP, the actual so-called classically called colles fracture, survives. So please, it's strictly colles fracture. Remember, a child can have a similar fracture, is not a colles fracture. It's basically a distal radius fracture. This particular one, you can't use below knee, below elbow, POP. We recommend you use above apo POP, and you have to use it longer than the usual 3 weeks or 4 weeks. So I just had to emphasize that to caution whoever is asking that, or the listeners, that it has to be strictly collapse fracture. If it's a space fracture, again, you have to be sure after reduction it's very stable for it to, or otherwise any other distal bridges fracture, it doesn't work.
All right. The next comment is from Boniface Ojwang. He thanks you for the good presentation, very informative. His
Welcome.
question is with regard to skin traction. Up to which point should it be applied? Above knee or below knee? And how do you calculate the desirable amount of pulling weight?
Thank you very well. I think a good guideline there is below the fracture, just to be immediately below the fracture point. So the question of below knee or above knee doesn't arise. However, below knee is below the fracture, if you're talking of fracture femur. But I think let the listener understand the principle, the guideline is below the fracture. Below the fracture. Determining the amount is, there is a formula. You weigh the patient, you take 5%. Or as a rule, never exceed 5 kgs for big guys.
Okay.
Yes.
Gerald Muneshi is asking, what are the contraindications for application of a hanging cast? And say something about fracture quartet from Dr. Lushula.
I will skip Dr. Zula's question. I can't say understand it. However, question 1, sorry, question 1 was what?
The first question is, what are the contraindications for application
yes.
of a hanging cast?
Well, once again, hanging cast, I haven't seen it used frequently in our Kenyan setup, but still a very useful POP to learn and use. Of course, people commonly use a U-slap. However, contraindication of POP or specifically hanging cast should be the general contraindication for use of POP or particularly a circular cast. Number one is open wounds. Yeah, that one, be very careful. Number 2, excess swearing. So do you fractures before there is excess swearing? The reason why you have to do immediately once you encounter fracture, it's easy because swelling has not set in, edema has not set in, and the soft tissues are easy to manipulate. Again, 3, compartment syndrome. Of course, there could be other relative contraindication like age. The elderlies, they don't cope well. It could be very heavy. It's cumbersome. Yeah, it's cumbersome, and other medical conditions, of course. Of course, if you have a floating elbow, it's contraindicated. Yeah, and there are other lists of contraindication one can look at. Those are the immediate ones I could remember. Thank you.
All right. The next question is from Philip Madadi. Thanks for the informative and educational presentation, Dr. Ongaro. His question is about BOET, whole injury management non-operatively with regard to the technique and time for intervention, and then kindly highlight on the pathophysiology.
Physiology of?
I think the BOET, whole injury. BOURTE.
Oh, right. Pass.
Okay, I think
Sounds
we
clear to
all
me.
need to check on that. I'm not familiar as
Yes.
well with it.
Yes. Yes.
Then Barak Abeid is thanking you for the presentation. Faraj, the recommended traction for proximal and distal femur fractures, I think that you said. What is the recommended position for forearm fractures? Is it features or fractures?
Thank you, Abid. Thanks, Abid, all the way from Voi. Forearm fractures. Forearm, first of all, I think given the audience that we are having, let's make one golden rule. Always, as much as possible, try to use surgery to fix forearm fractures, especially shaft, 2-2, okay, fractures. However, if you have a green stick and above elbow, of course, if there's no wound, the elbow at 90, neutral, and the forearm should be neutral, pronation, supination, or in pronation. In view of the fact that currently, because of the digitalization, the more preferred functional position is prone position. Now, if you got shaft fracture where the fracture is in the middle third, okay, divide your radius and ulnar shaft into 3, upper 3, middle 3, lower 3. I'm talking about the shaft, all right? Now, if you have in the middle, the challenge there is the pronation, supination function, and the pronation function of the pronator quadratus and the supinator muscle. All right. So you have to check this and ensure that if the fracture is on the upper third, all right, where you have the supinator, so you have to counter this muscle in your final POP position and molding. And if the fracture is distal, the lower 1/3, again, you have to mind the pronators, all right? And this is where you have in mind the Garecian Montecha type of fractures as well. Yeah, but one rule you could do in children, okay, in children, if you forget this, is to be in neutral positioning of you fracture. Therefore, as a simple rule, okay, I hope I'm not confusing anybody. If you have a proximal letters and ulnar shaft fracture, you should have your arm in supination, and if it is distal, you have in pronation, and then if it's the middle third, you have to be neutral. That's a general rule, but make sure before you put, check your text just a minute before, because when it confuses me, like when I'm discussing, but when I have the real patient, I just check a minute before I do my final position.
All right. Dr. Seve has added that for a hanging cast to work, a patient has to be mobile. Then he asks, what are acceptable fracture reductions?
Thank you so much, Dr. Msef, for that addition. Acceptable fracture reduction is what meets your specific fracture goal of treatment. So the biggest question you have to ask yourself when you got a fracture to manage non-operatively, the decision you're faced with must be guided by the goal of treatment, the goal of reduction, and the goal of treatment. Now, the goal of reduction will be dictated by, one, is the fracture displaced? If the answer is no, immobilize, you're done. Now, if the fracture is displaced, the question is, what's the displacement? Is it shortening, restore length? Is it angulation, medial, or internal, external? bring the limb to neutral. Is it angulation? What kind of angulation? All right. Is it destruction? Okay. Always in destructed fractures, remember the intervening soft tissues. It could be very difficult sometimes to do the reduction. All right. And overall is to reduce the limb to what it is functionally. And when you're applying your method, put the limb in desired respective joint functional and safe positions as you apply and mold the splint. But specific to the question is the goal of reduction and the goal of treatment. You have to address it, and once you've set the goal, and be the habit of writing down your goal of reduction. Am I addressing angulation? What type of angulation? Is it apex anterior, apex posterior, lateral, or is it another direction? So from what point to what point am I reducing? That goal is critical. Once you've achieved it through indirect methods, then hold your fracture by proper application and molding. Thank you.
All right. So maybe the last question before we have Benjamin come on board. Barak says, can we say most of the traction systems still in use should be obsolete? Considering cost of implication for traction in hospital might actually be more expensive than fixation, open, reduction, and fixation.
Yeah, yes or no?
Okay.
Yes, you can say they are obsolete when you have capacity, resources, and particularly safe surgery. Then you can say if you got ability and the patient can afford and is safe, you have the technical skill and experience, then you can treat your patients operatively for good outcome. But they are not absolute because while you're doing this operative treatment, you still need the non-operative techniques for temporary or for augmentation. Now, no, because there are some centers where you absolutely surgery is not available as an option. So they have to. Now, even in advanced centers, even in level 6 trauma centers, I'll still tell you non-operative principles are applicable. Non-operative methods are still applicable. You only need to have your indication. You only need to have your indication. All right. For example, why should you manage a non-displaced fracture? For example, stable non-displaced. Why should you say now managing this non-operative is obsolete, is archaic. So every fracture you see, you fix it. All right. And so don't yet throw away your techniques and tools. You may even be needing to use them for hours before surgery, okay, overnight, few days for transport, all right. So, and the knowledge about their use, okay, even to improvise, the principles with which they are used for safe application, and the techniques with which you have to apply them safely for the goal, you have to learn it. So the knowledge of non-operative methods, the knowledge, the principle is not obsolete yet, Dr. Abed. Yeah,
all right.
you still need it.
Zachary is requesting that the surgeons and the registrars be near them to give sedation and relaxation of muscles as they reduce fractures from where he works. Apanagos, I think this is a comment he's giving, I'm not sure, of a patient who had a Schatzger type 4 complex medial-tibial plateau fracture, couldn't afford an HIF, and couldn't afford surgery for plating. So he's asking whether that can heal without intervention.
Thank you. Very good question. Number one, let's say you are in the best centers where you have all the tools to fix that particular fracture operatively, and it's going to take you 6 hours or a day to go to theater. Please be aware that you still need to apply non-operative treatment of this particular fracture before you do surgery. The aim being give a patient comfort, you relieve pain, you immobilize the limb, you give the limb both physiological stability, okay, and what you call joint and muscle homeostasis, okay, and you can prevent complications like blisters, like compartment syndrome, while you are planning for that complicated open surgery. So the same listener is asking that, please use as simple as a back slab. Know how to apply a back slab, all right? Sometimes even after you've done your complex, operative surgery, you may do very well by using a patient back slab. Not that you're treating the fracture, but the fact that you're immobilizing and giving soft tissue support. So a back slab, even if for a day or a week, is already a non-operative method, even if you're not using it for that kind of complex surgery. A Robert Jones splint. And by the way, for general information, listeners, we do have courses that are run twice a year that actually you get exposure to application of all these splints. You have hands-on experience and practice. There are videos available. So let's not have this dismissal of non-operative management. They are part and parcel of patient safety and good fracture outcome. So even very complicated, let's say a floating knee, patient's going to take 2 days to go to theater. You need to know how to apply skin traction, skeletal traction, or a full-length back slab. You need to know as a doctor. And that goes a long way in patient comfort, limb safety, pain control, prevention of compartment syndrome, and even you can save the limb from vascular injury just by applying an non-operative treatment technique.
Last question, Dakari from Buva. What is the acceptable opposition of a fracture after reduction for a fracture to unite in terms of percentage?
Oh, I think if I read your question, thanks, the one who's asking, Dr. Buva, I think you're addressing yourself to a transverse fracture, which is usual type A, that has as a form of displacement we call translation. Now, this translation means the fractures are still intact, and this apposition could be graded from 100% if the fragments are together, anatomically, or it could be like 75% contact, 50% contact, 25% contact. All right. Now, when there is no contact, we call that fracture complete translation. Okay. Sometimes when there is complete translation, action of muscles or the primary mechanism can make the fragment overlap. That gives you an overlap displacement. Okay. So now let's go back to contact. If a fracture is in contact, 25 up to 100 is okay, it's acceptable. But tibia is a bit sensitive because it is cutaneous. You aim to make it as near 100 as possible. So I will accept anything between 75 and 100. Now for femur, you can even have up to 10% contact in children, and you're okay. You can even actually, the younger the children, we don't even encourage that you reduce in a way that you have 100% contact because of overgrowth issue. Allowing a bit of overlap is good enough. Now for neonates, You can even allow a very serious overlap, and is encouraged, because these kids will mold very well and do not have an overgrowth challenge. So your question, you can get your answer by looking at specific bone, specific age. And again, what is your goal? What is your goal of treatment, and what's your goal of reduction? Thank you.
All right. Thank you, Dr. Ongaro, for your